From Eyewitness News, this is Newsmakers.
Whether you call it Obamacare, the Affordable Care Act, or health reform, big changes are coming to medicine across the country, and Rhode Island is leading the pack. Officials are working around the clock to build HealthSource RI, the state's new health insurance marketplace, in time to start enrolling Rhode Islanders on October 1st. Meanwhile, state lawmakers are stepping up efforts to control the ever-rising costs of treatment in Rhode Island with the Rhode Island Healthcare Reform Act of 2013, a far-reaching bill signed by Governor Chafee this month. This week on Newsmakers, the future of healthcare in Rhode Island with Lieutenant Governor Elizabeth Roberts and State Senator Joshua Miller. Good morning. Welcome to Newsmakers. I'm Ted Nisi, filling in for Tim White. Joining me on the panel this week is Eyewitness News political analyst Arlene Violet and a first-time guest panelist on Newsmakers, and I'm glad to have her, Providence Journal medical writer Feliz Fryer. Good morning, everyone.
Well, welcome.
Good morning.
So I want to start off, Lieutenant Governor and Senator Miller. The big reason I wanted to have the two of you on, beyond just I like to get wonky about health policy when Tim gives me the keys to the show, is this bill that you sponsored, Senator, the Rhode Island Healthcare Reform Act of 2013, quite a name, and I know it came out of a legislative commission you chaired 2 years ago in part. Before we dive into the weeds on it, can you give me a sense, Senator, broadly of what the idea was behind this bill and what you hope it could accomplish?
Well, like you said, it came out of the commission that I chaired 2 years ago. And the evolution became more urgent with the ACA and HealthSource Rhode Island, our exchange that's coming in place in October. So these kind of reforms became much more important as we look to measure impact and act on them very quickly. And
you're looking very much in this at costs, at what's driving sort of the financial side of health reform, and we've seen Massachusetts looking at that too. Lieutenant Governor, one thing that was interesting to me was that there's a number of things in the bill that talk about mandated health care benefits in Rhode Island, review the impact of the current mandates, do a state-by-state comparison of insurance mandates, look at the purposes and objectives of any new mandates. It sounds like the people behind this bill are thinking maybe some of those mandates will need to be removed.
Well, and we had a conversation about this a year ago, a very public conversation, when we did something the federal law requires, which is created what we call essential health benefits for Rhode Island. Initially, we thought that was going to be a national decision. What should every health insurance package have in it that's sold in this country? But they turned back to the states and said, look at what the standard is in your community. And we had a lot of conversation. We actually had to add some services covered under insurance, dental care for kids, and habilitative services for people who have issues that need therapies. But there will be an ongoing conversation. Actually, the law prevents us from changing our mandates for a couple of years. So it's a good time for us to have that conversation.
On mandates, obviously you've been involved in this area for 20 plus years. You must have some sense of mandates that you think on a cost-benefit analysis should be optional and not in the product itself. What mandates do you think should get a second look as whether they should be optional or not?
Well, let me start with the ones that we shouldn't give a second look to, and people often talk poorly about mandates, but actually maternity coverage, pediatric coverage, those are actually mandates. You can buy insurance in some states that doesn't cover maternity care. There was a fascinating article in the New York Times recently about a family trying to manage that coverage. But there are some others I think deserve a look. Our Lyme disease mandate, we already did a look at our in vitro fertilization mandate and changed that a few years ago. These are difficult conversations, and actually I think the legislature I'm so glad the legislature looked at it, because it needs to be a public conversation. We need to have the community. You know, healthcare is a very personal issue. It's about your family, the people you care for. We need to make sure as we talk about these mandates, we talk about what are the community health needs and what should insurance in Rhode Island cover.
Senator, the original version of your bill had a fairly radical provision in it that would have given the health insurance commissioner authority to review contracts between insurers and hospitals and possibly disapprove of them. Why did you feel that was necessary at the time? And obviously this provision didn't survive, but is there anything in what did survive that would address those concerns?
What survived is careful analysis and a biannual review of all the things that could impact rate. So a lot of the things, including looking at mandates in this bill, are to get rid of myth and work with real statistics and real reality. So what we have left is something that gives us data to examine rates, but not necessarily have the full authority to look at contracts while they're in progress. The while they're in progress was the main concern from providers, mainly hospitals, was while they're in progress in negotiating, the ability to set rates was a problem for them. And we had to have them at the table in order to have a legislative package that was going to be fair and passable. And going back to the mandates, one of the things that was really important with the mandates was also to have all the statistics out there. There are two things that take place. The feds no longer have a match if you have a mandate going forward. Before they would have a match, they no longer do. And the second thing is people look at mandates as a very large component, a much larger component than in reality what the component is in your healthcare costs. It's about 2%, but it's much more of a conversation at the table than that 2% cost in anybody's health insurance.
Another interesting thing to me, we were talking about this in the meeting before the show, the bill talks about requiring the health department to review hospital reporting on pay and compensation and financial disclosure. Obviously what comes right to mind to me is when former Lifespan CEO George Vecchione got almost $9 million in 1 year because of a large one-time payout. But the fact that I know that shows that those numbers are already reported, and it doesn't look like the bill is gonna crack down too hard on that. I mean, do you see anything actually being done on high-level executive pay at the hospitals in Rhode Island?
Well, why it's important to have a certain financial disclosure component of this is that everybody's insurance is paying for reimbursement to hospitals. And how much marketing do you want to pay for? How much executive pay do you want to pay for? There are things other than healthcare that people pay for, including executive compensation. So what is left in the legislation after some of those conversations with some of the hospitals and others is that every nonprofit hospital is required to file what is called a federal 990, which is the federally required disclosure. But if people who are involved in policy are interested in looking at that, they might not necessarily want to go through a 140-page federal tax document. And so the legislation now requires a summary of that and a similar disclosure from a for-profit.
But let me ask the Lieutenant Governor, you've been involved in this for a long time. Lifespan is our largest private employer. It's a powerful force in the state economy. Is the state ever really going to do anything to deal with executive pay at an institution like that?
So I think sunlight is a valuable transparency is a theme throughout Senator Miller's bill, and I give him a lot of credit for that because healthcare is an incredibly complex, has a whole different set of accounting rules actually. When I went to business school, I focused on healthcare, and we had to learn a different set of accounting principles for hospitals than exist in other parts of industry. So I think it's really valuable. We actually regulate through the Health Insurance Commissioner the administrative structure at our insurance companies. He has the right to turn down an administrative rate part of your premium that pays for overhead. This bill doesn't go that far, but I think sunlight is always valuable, and you are helpful. You're right, you know that number. I think it's good that that's public information. These are public organizations. And I also agree with Senator Miller about private organizations. We have the potential of some private hospital systems here, and that information can be much harder to find, and I think we should have a level playing field.
But why
between
wouldn't it have been better, though, to give the same power to tinker with that administrative course? I mean, what happened? Did the General Assembly cave on that point?
Well, we didn't cave. We can't tinker with it. What it is it's a matter of...
You could have the health commissioner do it just like you do with insurance companies.
You can look at what a hospital, because we're talking about hospitals, there are other providers in the system, but hospitals, because of the private and for-profit and the non-profit, like the Lieutenant Governor is saying, we really want to level the playing field. But we also want people to understand, whether the policymakers or the public, now that they're entering exchange era, is to understand that there is a level that is beyond health care. We're not only paying for your health care, we're paying for how the hospital administration is paid for, and in an era and a geography like Rhode Island, where we have Massachusetts hospitals trying to get our patients, we're paying for marketing too. Mm-hmm. And how far do we want to go on that?
Well, the reason we're talking about hospitals is because they're so expensive, and they're probably the main reason why health insurance premiums are increasing. So what What lies ahead with that? We have what many would call a very inefficient system because there are so many little hospitals, many of them fighting with each other, and one right now where extensive resources are being devoted to shoring it up. What do you see in the future? Are we going to have hospitals close? What can be done to bring this under control?
And just to add to that, Feliz has reported that the recent report that was mandated by the General Assembly said we could have 200 extra hospital beds in this state within a few years.
We probably do now.
Right. So, and this is really a national conversation, and you're seeing it both around price regulation, and you saw that really fascinating Time magazine cover story around price and price variation. But we are everywhere across the country. Inpatient hospitalization, our use of hospitals for going in to the hospital and staying there has declined precipitously. So even in some of our big hospital systems in Rhode Island, you've got individual hospitals with much lower rates of inpatient stays. So this is a conversation that will continue, and hospitals are reconfiguring themselves as business organizations and focusing on outpatient services. Physician groups are changing what they do. We're looking at the state level to go, okay, how do we assure cost and quality, value for the community? What are the actual health burdens of the community so that our providers aren't chasing dollars but are actually working in partnership with us to improve health?
So at the surfeit of 200 beds, should something like Landmark continue to be in existence? Or is it
a very lively discussion right now, and I think geographically that's a hard argument to make.
You've been analyzing this for years.
So geographically, that's a hard argument to make, that Landmark is the one. Landmark suffers from a payer mix that has made it difficult to function as a business, and the very issue I just talked about. The burden of illness is actually a chronic disease and things that don't require people to be in hospitals. So what is our new business model? We have now, that's a court process, which is much more difficult than it is in our process right now, where we're working collaboratively with other hospitals around what is it going to be. Talk to Dennis Keefe at Care New England and the changes he's making at Kent Hospital, Pawtucket Memorial, around a much more outwardly focused, that it's not that you come into the hospital, that the hospital is reaching out into the community.
All right, we're heading up against a break, but before we go, I want to give a plug to a new column in the Providence Journal that you can read every other Sunday, I believe. You see the inaugural edition here from Feliz last week. And Feliz, can you give us just a quick sense? What do you plan to do with this column?
This is an opportunity to kind of look behind the news and analyze and connect the dots and give people some insights that they might not otherwise have on why things are happening the way they're happening.
Well, it's going to be a must-read, and I've been waiting a long time for it, so I'm glad. And every other Sunday in the Journal and on ProvidenceJournal.com, which has a new system there too. So we'll be back on Newsmakers with more talk about healthcare, the new exchange, Obamacare, and also Amber Alerts, which have been, of course, in the news this week. Stick with us on Newsmakers. Welcome back to Newsmakers. I'm Ted Nisi, filling in this weekend for Tim White, and I'm pleased to be joined on the panel by legendary Eyewitness News political analyst Arlene Violet and the esteemed medical writer for the Providence Journal, Feliz Fryer. And our guests are Lieutenant Governor Elizabeth Roberts and State Senator Joshua Miller. And when I talked to the Senate spokesman yesterday, he said you have our two out of three most recent health wonks from the state Senate, because you, of course, were a state senator yourself, Lieutenant Governor. So I want to play something for you. When we taped Executive Suite, our sister show yesterday, with Tufts Health Plan President and CEO Jim Roosevelt, and he confirmed that Tufts will join HealthSource RI, the insurance marketplace being created under Obamacare, the Affordable Care Act, in 2015, which will mean 4 insurers in there, and I know officials here are excited about that. But one of the things I asked Roosevelt is whether he's concerned the exchange would just become another marketplace dominated by Blue Cross, as the current one is. Let's take a listen at what he had to say.
It could be, but I don't think it will be. I think that in the small business offerings, United will give Blue Cross a run for its money. I think in the individual offerings, Neighborhood will give them a run for their money. And when we join, as we have done outside the exchange, I think we will offer fresh alternatives.
Governor, what do you think? Do you think that's right? Do you think this is going to lead to more competition in Rhode Island health insurance?
I do, actually. So one of the most important things about HealthSource RI is that it is an open marketplace. Right now, it is much harder to compare. I'm an individual, I'm a small business person. It's hard. It's a tough market to understand. This is going to open it up quite a bit. And I agree with Jim that Tufts is going to have a competitive plan. Neighborhood health plan will be in the individual market, which they have never been before. And there are going to be some differences. Tufts has been an innovator in Massachusetts, especially on their Connector, which is their exchange. So I think it's exciting. I think there's going to be more competition than people think, because consumers are going to be able to go in and go, oh, this, I need this, and who has that at the price point I'm looking for.
In addition, though, to this competition among the providers, we also have our own administrative costs. I think about $25 million to run this program. We've already spent that thus far. Why didn't we just join Massachusetts and cut out a lot of those administrative costs and just adopt their structure?
So we really wanted to meet the needs of Rhode Island's providers and the population. So we wanted to make sure. So what's going to be different is who's offering insurance, and actually we're going to have a significant difference, particularly for the small group. One of the places we learned a lot from Massachusetts, actually one of the areas, and they've really admitted it, they've been less successful, is with small employers, whether they're not-for-profit or for-profit. The small business community has not flocked to their connector. And we sat down with our business community and our brokers, who are part of our process as well, which they were not initially in Massachusetts, and said, how can we help the part of the market that has the worst time buying health insurance, small businesses? And so we've got a very different approach. It's where individual employees, the employer goes in and says, here's the level of insurance I can buy for you. You can then go on and go, you know what, this one would work better for me. And you can use what they've invested and make your own choice on HealthSource RI.
And so
that's a big difference.
So $25 million cost, though, would offset the benefit there? I mean, there's a cost-benefit analysis there, too.
So
we're spending more to have that happen as opposed to amending the other one.
The federal government is our investing partner, and we are also doing a lot of improvements in our Medicaid eligibility enrollment system, which we would have been doing anyway, and our public is good government, more cost-effective government. And on the ongoing basis, we are pushing inside government for a very lean and effective organization. Massachusetts would not have done it for us for free. So the building is a federal investment. We are very concerned about costs going forward, and we are your partner in making sure Rhode Island runs it effectively.
Do you think it will be difficult to convince small businesses to use the exchange? Nothing requires them to use it. Traditionally, they're very skeptical of anything the government does.
The component that the Lieutenant Governor was talking about as a small businessman, that component of turning over the decisions, almost all the decisions except making that initial declaration that this is the policy you like, but you can take that dollar amount and as an employee choose a plan that's higher or lower than that dollar amount and choose one of the other 24 products that the employer hasn't chosen. I think that's going to be incredibly attractive to both small business people and employees, so that the exchange will be attractive, and therefore the costs as we start having to pay for it can be spread out through a much larger population.
But won't there be a temptation just to say, I'll just skip the whole thing, my employees have an alternative now, they can go buy as individuals on the exchange? Is there a risk that that will happen?
So interestingly, that's been a risk in Massachusetts for the last 6 years, and they've seen employer-supported coverage increase in Massachusetts after this law was implemented. I think lots of people were worried about that, but it hasn't been what's happened.
Why?
Well, part of it is as an employer, you're trying to attract and retain as many talented people as you can. And offering health insurance is a key component in attracting and retaining talented people to be part of your business. And so that'll always happen, whether there's an exchange or not, how effective the exchange is. And so having a tool that gives them more participation and more ease I think is a win-win for employee and employer.
I want to talk about something else that is happening on the small employer side, and you're going to see more of it roll out over the coming year. But that is that small employers have largely had a little bit of a take it or leave it choice from the insurers. And one of the things that our HealthSource RI, our exchange, is doing is negotiating with the insurers for different kinds of insurance on that marketplace. So one with more of a focus on primary care, for example, things that can help you manage the cost of your employees more effectively. So that's another thing that we're offering to employers, is more say in what they're purchasing than they've been able to have in the current market structure.
We expect to see those rates by the end of this month, hopefully, on what it's actually going to cost on those plans. I want to pivot away from healthcare, Lieutenant Governor, and ask you about something that was in the news this week. There was, luckily, we're taping on Thursday, and she was found, but we did have an Amber Alert. And you, as the chair of the Emergency Management Advisory Council, have been very involved in the creation of Amber Alerts in Rhode Island. We're nearly a decade into that system. I'm curious, how do you think it's working, and what changes have you seen now compared to when it first started?
Right, so it started before my time as Lieutenant Governor, but it is a fascinating way of kind of linking the community and law enforcement. And you watched this week how quickly, having law enforcement reach out to the community and say, here's what we're looking for. And we've got our broadcasters, we're absolutely pivotal to it. DOT is involved because those go on the highway as well. The other huge change that's happened over the last few years is Twitter and Facebook engage in this as well. So those things just move like lightning. And you saw this week how quickly that kind of marriage of the community and law enforcement can turn results. I want to say something else we did a few years ago, and that was created a silver alert. And I've been very involved in a conversation about Alzheimer's and dementia and needs in the community. This is a really valuable, and we've actually in Rhode Island used it more recently for seniors or others who with dementia who wander or disappear from where they're supposed to be. And this has been another case where the community has gotten connected with law enforcement and we've been able to find people more quickly. It's very valuable. And boy, social media has really transformed it as well.
So Lincoln Chafee is now a Democrat. Are you going to support his re-election, and are you, because he's the incumbent?
Too early.
Too early. How will you
Lieutenant Governor?
decide?
How will I decide?
Yeah, what are you looking for in a
When
governor?
I see, when everybody's declared and we know who the field is for real. And that's how I'll decide.
Yeah.
So just
So
because
not
he became the
necessarily.
incumbent doesn't mean he definitely has you.
Right.
Not
Lincoln
yet,
Chafee.
Right.
but he's been a good partner for me as a legislator.
Okay, Lieutenant Governor, how about you?
And I will acknowledge that partnership as well. This has been a very, particularly compared to my first term, where I did not have an effective partnership with my governor. I've had a very strong partnership with
Really? That didn't
Lincoln
work? We
Chafee.
couldn't tell.
But I will also say that I'm actually proud as a Democrat, first of all, to welcome Lincoln Chafee to our party. He's someone, when I look at what he believes and what he's worked on, certainly in our partnership around health reform, he stands by a lot of Democratic principles. And I also want to say, as a Democrat, I'm proud of the people who are considering running for office statewide.
But you won't commit or will commit
including
to him?
governor. Right now, I am doing what Josh is doing, which is saying, let's keep our head down and get our work done, because these are all partners we work with. And I think it's really important. In a state this small, we need to be working effectively together as much as we can.
Lieutenant Governor, you've been living and breathing health policy since back in your Senate days. Do you see a role for yourself in the healthcare world after your term ends?
We should tell people you're term limited, so you can't run again,
Yes.
even
So
if you
I
wanted
leave
to.
in 18 months. I leave office, and actually, it is not just my legislative experience, but this is my education as well as my work experience before I came into government. So I love my work in healthcare. I have every desire to continue that work in the private sector or potentially government, whatever, public service around healthcare inside Rhode Island, in DC. I have all my options open. I think
Have you been
this
approached?
I have
by
actually
anyone?
once, and out of state. And I said, actually, I have a job right now. I can't consider that a job. But I really, and I believe this law is really, as difficult as its birth is nationally, is a really pivotal moment in our nation around healthcare, and I have every desire to stay involved in that going forward.
I want to ask you, Senator, I watched the House Finance Committee talk to Christy Ferguson, who's running HealthSource RI. That's obviously the lower chamber compared to yours, but there was a lot of concern among lawmakers, partly because they just didn't seem to know a lot about how this was going to roll out. But you're looked to as someone who understands health policy there. How are you feeling as we get toward the October 1st kickoff of enrollment for HealthSource RI? And do you think it's going to be ready, and do you think it's going the way you wanted it to?
I think it'll take time to get to its full potential, but I think in October it will be ready to present the products, and in January it will be ready to enroll people. And I think it'll be successful, attractive, and that the finances of it will be in place by the time we are independent of the federal government.
And Feliz was saying to me before we came on the air, she made a good point. Right now it's run under an executive order by Governor Chafee, which I believe is pretty rare, right, across the country?
Right, it's a
New York and Rhode Island.
New York and Rhode Island.
Yeah.
So do you think there's a need for the legislature to codify this in law, or maybe Governor Raimondo will come in and say, I want a whole different thing, or Governor Fung comes in and says, no Obamacare for us?
I think you'll see the structure as, if we hadn't done that, if that hadn't happened, if Governor Chafee hadn't done that, imagine the work that we have done since he did that and what the exchange would look like without all that work that we've done since he made that edict. So I feel that we're in a good place, and it'll be an important tool for many.
And I want to
lawmakers.
acknowledge that there is a real partnership with the legislature. So
Yeah.
we were very involved and supportive of Senator Miller's bill, which has a significant impact on what goes on with health reform. And there is ongoing dialogue and making sure that we are headed in a shared direction.
Yeah, what Ted's point is that should it be codified by the legislature and not just be subjected to who happens to sit in the governor's chair, because they can giveth, but they can also taketh away.
I think if
10
that
seconds.
happened, people will be reacting to a well-planned and well-implemented health exchange, and therefore we would be in a good place.
All right, that's all the time we have this week, but it's an exciting time to be a health policy wonk, I'd say, wouldn't you say, Feliz? There's plenty going on and a lot changing, and we're going to keep very close tabs on this at WPRI.com, on WPRI. Read Feliz's new column on every other Sunday in the Providence Journal. For Feliz Fryer and Arlene Violet, I'm Ted Nisi. I'll be back with you next week. We'll see you next week on Newsmakers.